Hi, everyone. This is Kathy Bush, and welcome to the DandleLION Medical Webinar on the Affective Capabilities and Vulnerabilities of the Hospitalized Infant. We're so pleased to have Mary Coughlin as our faculty presenter today, and Kathy Randall is also online with us to provide technical support and to assist with answering questions at the end. So let me tell you a little bit about Mary. She is an inspirational speaker, a motivational coach, and
Entry and exit chimes are off.
With a clinical background that spans over 30 years. A graduate from Northeastern University, where she received her baccalaureate and master's degrees in nursing, Mary served 7 years of active duty service in the United States Air Force Nurse Corps before transitioning to civilian practice. Mary is a seasoned staff nurse, charge nurse, and neonatal nurse practitioner, and is currently the president and founder of Caring Essentials Collaborative. A leader in the field of neonatal nursing and internationally recognized expert in the field of trauma-informed, age-appropriate care in the NICU, Mary is a published author with credits that include Clinical Practice Guidelines for Age-Appropriate Care of the Premature and Critically Ill Hospitalized Infant, written for the National Association of Neonatal Nursing, and also a book called Transformative Nursing in the NICU, Trauma-Informed, Age-Appropriate Care. Mary has a new book that is going to be coming out in August, and there's a link to the flyer on the left there in the chat box. The new book is called Trauma-Informed Care in the NICU, Evidence-Based Practice Guidelines for Transdisciplinary Neonatal Clinicians. Also in the chat area, you will see a link to the PDF of her slides. For those of you listening to the recording, those will be available in the resource section in the email that you received. So Mary, we're ready to hear from you, and thanks so much for being with us today.
All right. Well, thank you very much. I'm Kathy, and I'd like to thank Kathy Randall as well as, and in addition, DandleLION Medical for this opportunity to speak with you guys and share this information about the affective capabilities of the hospitalized infant. So just to kind of kick it off and give you some inspiration from Voltaire, that which touches the heart is engraved in the memory. And I think it's a really awesome quote to start this talk with, because historically, at least in my practice, I really underestimated the emotional capabilities of the hospitalized infant. During my clinical practice, I was very preoccupied with managing their medical needs, managing their surgical situations, tubes, lines, the whole kit and caboodle, and missed opportunities to really acknowledge the shared humanity that we have with the people that we serve. So I'm hoping at the end of this talk to really enlighten you about those capabilities and hopefully facilitate transformation in your clinical practice. At the end of this session, I hope you'll be able to understand or list rather some of the primary sensory afferents that are innervating human skin, explain the difference between emotions and feelings, describe or maybe at least understand the concept of neuroception, and then identify 2 caregiving activities that you do in your routine practice that will be transformed as a result of this new knowledge. So I'm going to start off with a little video. If any of you guys have heard me speak before, you know I'm obsessed with YouTube. So kick it off, Kath. I don't know how many of you guys have had the opportunity to see the movie Inside Out. I think it really should be a must-view type of a experience, especially for people that are going into neonatal practice. Kathy, how do I get the slides to come back up?
I'm switching them for you.
Oh, sorry, guys. The reason why I show you this video is that we know biologically that individuals, as premature as viability allows, are able to experience emotions. Emotions and emotion regulation is a crucial process that human beings utilize in order to adapt to the world around us. Unfortunately, individuals that have challenges in regulating their emotions are actually at high risk for psychological pathologies later in life. Emotion dysregulation is a root cause of such disorders as schizophrenia, depression, and other significant psychological pathologies. So the importance of this is pretty profound. Do I hit anything?
Sorry, no, it's not loading, so I'm trying to swap it around here for you.
Okay. So, and I'll just keep on talking if you guys are okay with that. Neuroanatomically, we historically would think of emotions as being relegated specifically to the limbic system or the subcortical structures that are involved around the amygdala, the hippocampus. And more recently, we're being informed that the brainstem plays a major role in the experience of emotions. But now, again, as the science is becoming more apparent to us, we're understanding that although the point where an experience is interpreted at an emotional level may be at these subcortical structures, that these subcortical regions actually have multiple connections to cortical areas. So for example, the prefrontal cortex is involved in emotion experience. Temporal lobe is also involved in the experience of emotions. I'm just going to advance this. But again, we historically have understood these phenomena to be related to subcortical or limbic structures, as I have highlighted here. But recently now we've been informed by science and research that's been really amazing for us that the organs of emotion are really pervasive across the central nervous system. And so when we presume that the premature or the critically ill individual doesn't have the neurological capacity to experience emotions, that has now been refuted biologically and neurobiologically. We know that they do have many of these structures and that they do have an experience of emotion. What we need to be mindful of is that emotion and feelings are very different things. And I don't want to get ahead of myself. So let's just talk about this concept of what triggers an emotion. Now, there are two different things that trigger emotion. There's a physical phenomenon that will trigger an emotion. And then there's also this concept called neuroception that also triggers emotions, which I will talk about shortly. From a physical perspective, we have the capabilities of experiencing emotions through the surface of our skin. Historically, we've done an exhaustive amount of research about the sense of touch, and we focus primarily on the discriminative capabilities of skin. And discriminative, what that means is basically being able to distinguish sharp from soft, hot from cold, and pain also is a discriminative capability of skin. But more recently, through the work of this guy, McGlone, and the people that he works with, we now understand that the hairy skin, which I know for premature people can basically be their whole body, but the hairy skin, which is everything that is outside of the palms of your hands, the soles of your feet. Those are called glabrous skin areas. But there's no skin, there's no hair on the palms of your hands generally, or the soles of your feet. But the hairy skin actually has now these special afferent nerve fibers called C afferent fibers that are responsible for hedonic experiences or sensual touch. And there's a valence to sensual touch. So do you remember, or at least when I was a baby NICU nurse, I would be told, we shouldn't stroke the baby. We shouldn't, rub the baby or, pat the baby in a stroking fashion, because that could be perceived as painful and it's very irritating. And that may very well be true, but it's a highly individualized experience. There's a valence to touch that maybe for you or I, somebody, rubbing, and I'm sitting here at my desk stroking my forearm, but someone stroking your forearm, there may be a point where it's pleasant, but then maybe too much or too quickly of a stroking may actually have a negative valence, or it may be annoying to you. So we know that these C fibers have that capability. And so it's important for us to be mindful when we're having these interactions with the infants and being aware of their emotional experience, that we're paying attention to their response. Whether it's cue-based response, or if it's an autonomic response, or if it's that experience that you have when you sense someone else is feeling good or they're not feeling so well. When we look kind of more discreetly at these different afferent fibers that are part of the skin, we can see that there are different receptor types, and then what they mediate, discriminative touch or emotional touch, and then the conduction velocity. And you can see that discriminative touch velocity is very quick. Your body very quickly must discern whether or not something is sharp or hot, or not, in order to have the appropriate safety response. But you'll notice at the bottom of this table, the C fibers, these low threshold mechanoreceptors that are responsible for emotional touch, they have a relatively low conduction velocity. Have you ever had the experience where someone may come up and touch you, and there's a bit of a delayed reaction or a delayed acknowledgement that there's a touch going on? And that's, again, because of this low velocity, low conduction velocity. The same thing in infants, all right? They're going to have a slow velocity response to a tactile experience. And what's cool about that is it gives you the opportunity then to monitor their response. They are having either a positive response or they're having a negative response. And at the brain level, and more specifically at the brain stem level, what they're doing is they're discerning, is this a safe experience or is this a threatening experience? And that's emotion. The emotion is your body's interpretation of something that is happening, either outside or inside. Outside stimuli are called exteroceptive types of experiences. They're happening outside of your body, and they're affecting your body in a certain way. Interoceptive types of experiences are things like hunger, having a grumbly tummy, or having shortness of breath. For many of our babies that have, respiratory distress or other types of pulmonary conditions, having shortness of breath elicits an emotion. It elicits an emotion of anxiety that can then turn into fear or panic. And you sometimes see this on the look on the patients that you're caring for. I'm thinking specifically of when I'm suctioning a baby, for example, and I'm literally taking their breath away. You can watch the panic in their face. And obviously it's a medically necessary procedure. And so being mindful of the emotional experience that they're having in relation to that intervention is really important so that you can manage their experience and manage that emotion. Because with every single emotional encounter, there is a cascade of neurochemical phenomenon. There is movement at the molecular level happening inside that individual's body. And again, remember Hebb's law. Neurons that fire together wire together. When a stimulation happens repeatedly, it then programs the body to respond in a certain way as a safety mechanism. I hope I'm explaining this okay, and I want you to really sing out with good questions at the end if I'm making this confusing. As these C-tactile afferent fibers are stimulated at this surface of the skin, they ascend the afferent pathway. They travel up. For example, if you're touching someone on the forearm, that afferent impulse travels up to the level of the spinal cord, and then from there, if it's a positive touch, there will be no recoil. The individual will be enjoying the experience, and that afferent impulse then travels up to the brain, and instead of kind of bifurcating and going over to the somatosensory, there may be that interpretation that this is positive, which gets read, if you will, at the level of the insular cortex, which is it's a cool little part of the brain that's tucked underneath the temporal lobe that we now know is responsible for not only emotions but learning, how people make you feel, and learning about the world around you. And this insular cortex is also then connected with the frontal cortex, with the occipital lobe, and all of these other sublimbic structures that help us interpret the world around us. And so I love this quote by, the guy, his name is McGlone. Oh, I think I misspelled his name on the slide, but McGlone, in telling us that the importance of the C-tactile afferents is not just to sense the physical world, but to feel the physical world. And I want you to just think about that on your own, okay? I mean, sensing something and feeling something. The feeling part enriches the sensory experience, right? I mean, to just feel something cold, you can't divorce yourself from a feeling when you sense something. By default, there will be a feeling experience after the sensory experience, or the sensory stimuli is interpreted internally. So again, we start asking, ourselves, what are the capabilities of the babies? Do they really have these feelings? And some people will even say, does it matter? Because they don't remember a lot of these experiences. They may not remember it at a level where we can recall things, but they will remember it at a very core, in a very core way, based on how that experience made them feel. So they will be, basically, they may have a heightened fearfulness around meeting new people. They may have a heightened fearfulness when they are brought back into the NICU, and all the sensory experiences, hit them again, and they are brought back from a memory perspective to when they were hospitalized in the NICU. They're having a feeling about that, even though they may not remember the details about that. So we rely on babies to communicate their experiences, their feelings, if you will, by looking at their cues, and by also looking at their autonomic feedback, their heart rate, their blood pressure, their oxygen saturation, and that sort of thing. But look at this little guy. Is he having a feeling? Is he having an emotion? Or what about this little person? And I understand now, these guys, these are not the people that you see in the NICU. And even though they're newborns, they still have the capacity to express an emotion, to express a feeling that we can relate to. So why would we think the people that we're serving in the NICU are any less capable? So I want to show you this next video. Some of you guys might have seen it before, but it really, I think, highlights the sensitivity from an emotional perspective of an infant. Go ahead, Kath.
something that we started studying years ago. When in could engage in social interaction. And this still face experiment with me. She sits down and she's playing with her baby. It's about a year. And she gives a greeting to the baby. Back to her. This baby starts pointing in different places in the world, trying to engage her and play with her. And working to coordinate their emotions, their intentions, what they want. That's really what. Then we ask the mother not respond to the baby. The baby very quickly picks up on it. Then she uses to try and get the mother back. She smiles at the mother. She points because she's used to the mother. She points. Baby puts both hands up in front of her and says, "What's happening here?" She makes that screechy sound at the mother, like, "Come on, why aren't we doing this?" It's 2 minutes when we get normal negative emotions. Feel the stress of it. They actually lose posture because of the stress. That normal stuff that we all do. Bad is something bad happens, but the infant can overcome it. After all, stop this little face. Ugly is to get stuck.
So again, I know the infant in this particular video is an older infant, not somebody that we usually see in the newborn intensive care unit, but you can see, though, because of this individual's level of maturity, they were really able to express their displeasure with what was happening with their mom. Ed Tronick actually began his work looking at the effects of maternal depression on infant development, and he was the one that created this little still face exercise. And I think the child just does such a wonderful job, not only demonstrating their displeasure with mom kind of being silent there, but also when mom comes back and they can play again and that sort of thing. That relationship there highlights a secure attachment. If you think about the babies that we're serving in the newborn intensive care unit, however, they don't have a secure attachment. We may feel attached to them, but because of how we work in our shifts, they've got a new face, a new person that they're interacting with. They don't have that consistency, that we need to have as normal human beings or healthy human beings. That actually wreaks havoc with their emotional integrity. They feel lost, they feel disconnected, and we need to be mindful of that. They're having an emotional experience with every single encounter. Emotions are what make us human. And what's really cool about the word emotion is the word motion is in there, okay? Again, as I mentioned earlier, when we have an emotion, when we experience an emotion, we experience it at an unconscious level. Emotions are unconscious, and they elicit a cascade of neurochemical and biological responses dependent on whatever the stimulation is. And it's the feeling that we then experience. Feelings are the perceptions of an emotion. So something's already happened, and then we become aware of what's happening in our body. For example, you're greeting somebody at the airport, and you haven't seen them for a long, long time. And you've been excited about it. You're conscious maybe of looking forward to it, but once you see that person and you're overcome and you're all joyful, that's the feeling that comes after your biological experience, which is the emotion. So babies are very capable of having emotions. Their ability to interpret and perceive these experiences as feelings are limited. They will perceive these emotions as either positive or negative valence is basically how they experience it. And for us as fully mature individuals, we have an array of descriptors that we use to describe our different feelings. So they may come under the umbrella of joy, but being joyful is a little bit more potent than I'm pretty happy or I'm pretty satisfied. I mean, it's still a positive emotion or a positive feeling, but there's a richness in how we can experience those. For babies, it's generally, and again, we don't know, this is as much as we know right now based on the science, but they are capable of interpreting a positive experience, which interprets to them, it is translated to them as being safe, or a negative experience, which translates as being a threat. But they are fully capable of having emotions and fully capable of having feelings. And I thought this was a cute little cartoon, the brain saying, I hate when you look at me like an idiot. Oftentimes our heart will lead us in ways that our head may not take us. And there's actually a biological phenomenon associated with that. Oh, I'm sorry. I'm looking at the chats and stuff like that. I apologize for the difficulties with the video. And when you get the handouts, the URLs are in there. And so you could look at the video at your own leisure and hopefully not have any more challenges technologically speaking. But I'm sure many of you have had the experience where your brain has told you one thing, but you've followed your heart. And I think it's back to Darwin, where he was the first one to say that the heart and the brain were very interconnected. And now we know the vehicle in which they are interconnected is through the vagus nerve, which is not only connected to the brain and the heart, but to many other organ structures as well, and plays a very important role in our experience with the world, which is consequently our experience with emotions and feelings. Again, just to kind of punch you back in the face there about these organs of emotion, they're diffuse. They span the entire central nervous system. And here are the key constructs that I've already talked about earlier. But all of the associated neural networks that connect these different parts of the central nervous system with each other are also part of the process, and the vagus nerve plays a big role. So what the neuroscience is really telling us about the significance of any kind of emotion, it's really about how these experiences keep us alive, keep us safe. And so, again, think about the baby. They're getting that same kind of input. This is either a positive experience or it's not. Think about a baby who may be having a negative experience. I mean, good golly, there's only a million of them in the NICU. They're getting a heel stick. How are they responding to the heel stick? Now, you may see one infant respond with a desperate attempt to recoil their leg away from the perpetrator. Maybe some flailing. You may see some tachycardia. You may see some oxygen desaturation. What are they doing? Well, they've identified that this situation induces distress in them. All right. I mean, I could color it with a lot of different words, fear, panic, but it definitely has been associated with a negative experience. And they are trying to survive. They are trying to adapt, and fight or flight response is being activated as a defense mechanism to protect them. Or you may see the response on the other end of the spectrum, where the infant is withdrawn and they're just lying there and you don't see any response. And sometimes we label these individuals as, oh, they're a good patient because they don't put up a fuss when I do these things. They just lay back and chill and let me do what it is I need to do. And in fact, that's not good behavior. They're withdrawn. Their response is it actually is a very foreboding type of a coping mechanism that will not serve them well down the road. Withdrawing and not putting up a fight when someone is threatening you. And I know that's not our intention. I understand these are medically necessary, but gee whiz, we really need to start thinking a little bit differently about the experience that these individuals are having, because again, it colors how they will interpret the world well beyond the NICU. So, again, just to kind of highlight, the amygdala structure, and that's here on the bottom, the central bottom part of the screen here, plays a really primary role, particularly with negative experiences, fear-inducing experiences that actually can tip over into panic. And if you can follow how it is connected here, to the right, it's connected to the hippocampus, or our memory banks. To the left, it is directly connected to the olfactory bulb, our sense of smell, which again, from a primitive perspective, which again, we've all evolved from the same creatures that came out of the lagoon and have evolved over time and matured and finessed, and we are now human beings, and we think we're just rocking it. But there's a lot of our mammalian colleagues or cohorts, I'm not sure how to refer to them, but our mammalian cousins maybe, that have a very similar structure, specifically around reading threat and reading safety. And it's based on these sensory experiences, not always visual, but smell plays a very, very key role. Think about, have any of you guys ever had an olfactory memory? You smell something and it immediately you have this feeling of either a positive thing or a negative thing. I know you've seen these babies come back into the NICU. I don't think we're as mindful of the smells in the NICU as these individuals are. When I come into the NICU, it just smells like what it smells like, because I've been smelling this for as many years as I've been there, and I don't notice it anymore. But these individuals, they're associating these sensory experiences, smells, sounds, tastes, depending on how involved they get back when they come back to the NICU, with their history, with their experience. And again, even if they can't articulate what happened, it is evoking a visceral or an emotional response in them. They are highly capable of having emotions. An emotion consists of a well-orchestrated set of alterations in the body that affect not only our neural architecture, but also our autonomic functionings. To feel an emotion is very simply the process of perceiving what is going on in our organs. So when you feel hungry, you are becoming aware that the leptin and ghrelin hormone systems are activated in one direction or the other. I don't want to get off on that, but you're becoming aware that something's happening in your body. That's the feeling bit, and that there's lots of cortical structures and subcortical structures that are responsible for this. And the people that we serve in the NICU, regardless of their prematurity, have these central nervous system structures. What happens in the vagus doesn't stay in the vagus. The vagus has 3 roots that arise from the brainstem, and they traverse all of these different organ structures. So it won't surprise you that perceiving that there's a threat at an unconscious level will cause your heart rate to quicken, or it may cause you to take a pause in your breath, catch your breath, or it may cause your stomach to start twisting, and your awareness that your stomach is upset is the feeling, but the emotion happened at a subconscious level. And it arises at the level of the brainstem. And then, of course, all the other parts of the brain get involved. But a Darwinian quote here, which captures it, I think, beautifully. When the heart is affected, it reacts on the brain. And the state of the brain, again, reacts through the vagus nerve on the heart. So that under any excitement, there will be mutual action and reaction between these 2 very important organs. If you think about just taking the enteric, the brain enteric axis, okay, how the brain is connected to our gut. I think you can appreciate then how this vagus system works. Adults that have had a lot of stress, not just like work stress, but like life stress and that sort of thing, are at higher risk of having things like irritable bowel syndrome, ulcerative colitis, other types of GI phenomenon, ulcers in general. So we know that our emotions wreak havoc with our health and our well-being, not only physiologically, but also psychologically as well. As I mentioned at the beginning, the importance of being able to regulate your emotions. Have you ever met the individual, or it could even be, the toddler that you're seeing in follow-up clinic, who has limited capacity? I mean, toddlers in general have a limited capacity to regulate their emotions. But in individuals that have had a trauma history or have had adversity in their very, very young life, you will see even less capability of regulating emotion. That, if they're building blocks and one of the blocks falls on the floor, they may just go into a complete tizzy fit and start screaming and carrying on. They're unable to regulate, and they need the adult to guide them and support them and coach them, if you will, through loving reassurance that everything is okay. And that's what our job is in the NICU, is to help coach, support, and regulate these individuals that are undergoing life-threatening interventions. They're experiencing critical illness. We need to help these individuals cope with their reality by being present, by acknowledging our shared humanity at that emotional level. That's what gets us through as adults, and it's what gets all human beings, and truly all mammals, through difficult times. The work of this really brilliant scientist, Stephen Porges, has really made a big impact on our understanding of emotions and how emotions are regulated by other people in our world. He was the one that developed this concept called the Polyvagal Theory, and he actually started out his research looking at newborns and trying to understand how newborns were handling the stress of birth, and then how they were handling separation from their mother and all this other kind of stuff. And he came up with this very elaborate theory. I think his first paper came out in 2001, and he's gone on to refine it. And what he's now able to share with us is this concept of neuroception. And neuroception is an unconscious surveillance of the environment. So we think we're like, all that and more because, well, we look around and we see things, and then we make a determination whether or not the fact that Barbara is walking towards me with a grimace on her face is a good thing or a bad thing. I can figure that one out real quick. But neuroception is taking that vision piece right out of the equation and actually sensing at an unconscious level whether or not there's a threat. And I want you guys to think, has there ever been a situation, maybe, you just finished the 3 to 11 shift and you're walking to the garage and you get some kind of an uneasy feeling, or the hair on the back of your neck starts to get, stimulated and rise up, and you move a little bit more quickly and you get into the car, lock the car doors, and then you feel a little bit safe. That experience is neuroception. That sensing without seeing, but sensing at a very primitive level that there's a threat about to happen. We can perceive these threats inside or outside of our body. For example, the dyspnea thing. This is a little bit embarrassing, but I'm going to tell you anyways. It's kind of yucky, but I was out at a family gathering, and we were having dinner, and I was eating and talking at the same time, which I do not recommend for anybody for safety reasons, because of course I'm talking my head off, and I didn't chew my food all the way, and I started to choke on the food. And it's just so weird how you think about these things, but it was almost like before it actually got lodged, I had a sense of, oh crap, this is bad. And that was neuroception. And fortunately, somebody Heimlicked me and I was all fine. But again, it's that unconscious thing, like, I'm heading in the wrong direction. And my cortex is not driving the car at that moment. It's my subcortex, it's my brainstem that's really interpreting what's happening. These same capabilities exist in the patients that we're serving. And you see this, guys, I think sometimes because of the way we've been raised as NICU clinicians, we dismiss it, we minimize it because we were never instructed at this level of capabilities. We were always taught that these individuals, their brains are immature. So, I mean, think about the whole pain thing, right? How we felt that they didn't even experience pain. We are now having our eyes open to the capabilities of these individuals, and they mirror ours. They may not be as elaborate, they may not be as articulate, but they are still experiences that are associated with emotions, and their feelings, are positive or negative, are something we really need to be tuned into. So this neuroception is mediated by the nervous system, and it basically helps us determine, are we safe? Are we in danger? Are we in a life-threatening situation? And then at the bottom of this little diagram, you'll see for safety, then what we do is we respond in kind to the caregiver. So if I'm going to put a feeding tube into you, and you're a small person, you're born at 27 weeks gestation, but I've got your mom there, and your mom is holding you, and I'm talking, and the mom's talking, and I'm giving you maybe a little sucrose, and we're watching your face. We're not overstimulating you. We're watching, and we're going at your pace. I'm going to do a nasal tube insertion. I'm going to put a little bit of lubricant on the tip of the feeding tube. I'm going to advance it into the nose. You're going to wince, but I'm going to pause, and I'm going to watch you, and I'm going to reassure you. I'm going to have mommy reassure you. Then I'm going to watch you swallow as you're sucking on the pacifier. And when you take that swallow, I'm going to try and coordinate my feeding tube advancement with your swallowing so that I can respect the experience that you're having. I know this is the worst thing, well, one of the worst things that's going to happen to you, but I can make it a little bit less bad by being in tune with you and attuning to your experience, recognizing that you are having an experience, you are having an emotional experience. Danger, again, that's that fight or flight thing, and you see that every time as a nurse, when you touch that little baby's foot, they recoil. Why? Because their experience, their emotional experience, their feeling around somebody touching their foot has always been painful. And we can change that. And then, of course, the life-threatening one. And I align that with the endotracheal tube suctioning. That, I mean, we know that we're not going to let the patient die, but the patient doesn't know that. Their experience is terrifying. We are literally taking the breath away from them. So how can we make that less terrifying? Stress and fear will get hardwired into the brain. And these brain structures, the amygdala, the hippocampus, and the prefrontal cortex, are actively involved in this phenomenon of conditioning for fear. Overwhelming stress and early exposure to trauma and being critically ill, have a life-threatening situation, being separated from your mom and dad is a traumatic life event. And it produces high levels of catecholamines and cortisols and all that other kind of stuff that bathes your brain. And your brain and your body are designed for survival. And so if these experiences have posed a threat to you, you're going to have a heightened response to the next encounter you have with a caregiver, because it's always a terrifying thing. And so our susceptibility, I apologize, I went too quick. There's, certainly, kind of pre-existing sensitivities to experiences based on transgenerational experiences and our gene influence. But the learning of the learning of fear is really what we actually may be cultivating in our practice if we're not mindful, if we're not attuned to the experience of the patient. And what happens in the learning of fear is that then these experiences, with the cascade of catecholamines and neurochemical mediators that are telling the brain, okay, this really sucks. When they touch us here, this is really terrifying. These things get consolidated, and then you'll start seeing that conditioned response. And we see this already. We need to change this significantly because this is going to have lifelong implications for these individuals. Imagine not ever wanting to be hugged, be touched, to have some, a fear response or a panic response based on a touch. I just want you to think about the magnitude of that and how that would alter the quality of your life. Infants make meaning out of their experiences. And unlike us, their meaning making starts at the level of the brainstem based on how the body is experiencing a certain situation, how they feel, and how that feeling, is an emotion, becomes an emotion that then wires out to all of the other parts of the brain in the neocortex and decides that these experiences are bad, that the world is not a safe place. The world is a really, really scary place, and be very careful. Be cautious. And again, those behaviors that instruct the body to be cautious in the NICU may not serve you when you're in preschool, may not serve you when you're trying to get a job. Attachment-related patterns contribute to the organization of biological pathways in the brain and body that underlie emotion regulation capacities and mental representations of the self and other. We figure out as human beings how scary the world is based on our relationship with other. And if we don't have a relationship with other, then we are going to be super cautious about how we interact and engage with the world. But if we have caring relationships, caring adults that support us and nurture us and attune to us and are mindful of our experiences and validate our experience by being calm and loving and cautious with our procedures, then we'll have a different, kind of experience and a different kind of outcome. But even, and this is not just unique to the NICU, but a lot of nurses, don't connect on a human level with their patients. And so even if the adult is present, if it's not an authentic presence, if they're not mindful and attuned to the healing experience, then it's just as bad as not having anybody there, and it could even be worse. We know that these experiences in the NICU change the developmental trajectory of the individual, not only psycho-emotionally, but also physically. We know that babies will have compromised cortical development when they're born preterm. And this is an excellent paper that actually highlighted that it was the insula cortex that had a significant compromise in cortical folding, which is basically the amount of surface area, right? Your brain folds to give you more brain surface area. And that the insula, that part of the brain that plays a key role in emotion processing and experiencing and feeling, is really underdeveloped. And why is that? I mean, we don't have an answer as to why that is, but one could consider that it's not getting the proper input, it's not getting the proper stimulation. And that's where we come in, not as I want you to love your patients and be kind, but I want you to primarily facilitate that parental attachment, that relationship that is so quintessential to healthy development and outcomes for these individuals. In a very interesting paper that talked about this from kind of a psychological, existential kind of perspective, I exist because there is you. The experience with other helps us understand and know ourselves. And we develop meaning around ourselves or value of ourselves based on those experiences with other. And we are creating these experiences for the babies that we're serving in the newborn intensive care unit. It's an absolute certainty that no one knows his or her own beauty or perceives their sense of worth until it is reflected back in the mirror of another loving, caring human being. So, with every care encounter, if you're just reaching in, flipping and stripping and doing them up because it's 8 o'clock and you're just, very task focused, what you're telling that individual at a human level, at an emotional level is, you're not important. You don't matter. I matter. I'm important because I've got all this work that I have to do. And I can assuage any guilt because you won't remember this. But in fact, you will remember this. These people do remember. They remember at a cellular level. They remember at that quintessential soul level of what it is to be human. Empathy is our biggest tool, if you will, the thing that we can really call upon to engage with our patients in a very meaningful way. This quote from Henry David Thoreau, I actually pulled off of a really cool video that the folks at Cleveland Clinic did about empathy. And I'm not going to pull this video up talking about empathy. I invite you to check it out when you download the slides, and you can look at it. It's a video by Brene Brown doing a comparison between empathy and sympathy. And where sympathy is feeling sorry for somebody else, but not really changing anything, it's empathy. It's not only feeling bad, but really walking in that person's shoes, imagining what it would be like to be naked, alone, on a warming table, with your little arms tied down because somebody's doing something to your belly button, and nobody's there, and there are bright lights, and there's lots of noise, and you're having anxiety or whatever inside. You're having a negatively valenced emotional experience that no one seems to be recognizing. And that's like the secret sauce of what we can offer these individuals. They're critically ill. It sucks being in the NICU. It sucks being that patient, but we can make it suck a little bit less by acknowledging the shared humanity that we have and honoring them at that emotional level. If our first rule is do no harm, we have a great opportunity then to do no harm, because these distressing experiences cause harm by activating the autonomic nervous system, initiating that fight or flight response, and changing the developmental trajectory of these individuals with these repeated occurrences. I'm a big Dr. Seuss freak, so I stole this one from the Lorax, but I really think it's powerful for what we're talking about today. I know it may seem small and insignificant, but it's not about what it is. It's about what it can become. What can our practice become when we honor other, when we recognize the capabilities of these individuals, that they mirror our capabilities, but we're all different. I experience joy differently than you experience joy, differently than the baby that's the 24-weeker experiences it, but it's still very valid and very important. So I want to thank you guys for your time and invite you to for any questions. I'm going to shamelessly show off my new book, which I'm wicked excited about, and then turn the mic over to Kathy and Kathy.
Mary, thank you so much. We really, really appreciate your talk and your really cutting-edge information. Right now we're going to open up to questions. So if people would write any questions you want in the chat area.
You can share any of this stuff with the unit. You can have the slides, Robin, who just wrote that. Go crazy.
So does anybody have any questions for Mary? A lot of it, I think, is just one of those things where you kind of have to marinate with it a little bit.
Well,
it's very eye-opening.
Please feel free to email me if you have any questions about anything, or if a question comes up later on, I'm happy to clarify for you.
So there's a question from a child life specialist just asking about, partnering to be able to provide more sensitivity and to, of course, take in your concept of trauma-informed care, and how can someone in that role, in a child life specialist role, embrace these and practice this?
I think, it's tough, because I think, there's not, when you look at the ratio of child life specialists to the number of patients that you're serving, I can totally see it can be a little bit overwhelming. But I would suggest, maybe reaching out to the nurses and say, I know you've got baby so-and-so, and he probably is going to have some painful or stressful procedures done today. I'd be happy to support the baby if the parents aren't here during these difficult situations. And when you do that, the nurse might say, yeah, sure, if if you're free, that would be cool. They may not be totally bought in, but it's an opportunity for you as a teaching moment to then, as you're supporting the baby, maybe draw the nurse's attention to, gee, look at how calm the child is, or, does he have a pacifier? Can I use the pacifier? Really kind of use it as a teaching moment to try and drive home the benefits of four-handed care. And it doesn't always have to be a super invasive procedure, although I strongly endorse that for invasive procedures. But even for more simple routine procedures, having that extra set of hands when the parent isn't there, or even maybe suggesting to the nurse that if the child life specialist has the time, is it all right if we get the parents? I just saw them come in. Can they come over and I can coach them while you do your procedure? Because a lot of times, just talking from a nursing perspective, we might be like, geez, Louise, I only have a few minutes. I got to get this done because I got to do up my other patient. I don't have time to teach them. And, take that off their plate. Say, I'm happy to help instruct the parents on this, and you could even do a mock-up with a doll and teach the parents, and then mentor them at the bedside with the nurse. There's lots of really cool ways. I think that you play such a vital role. I wish I had the opportunity to work with child life specialists. Someone asked about NAS in the book. I don't specifically talk about any particular pathologies. The book is really focused on these evidence-based guidelines in a broad perspective around all patient situations. So I apologize, if it's not specific, but I think what's in the book definitely applies to individuals with NAS.
There's a question here, Mary, about sometimes we work with colleagues who are more checklist oriented, and it's task orientation. And what practical things have you seen in your experience, I know, around the world in helping to bring some of this awareness and mindfulness? What are the practices that people can do in 5 seconds or 10 seconds or during that hand washing before they enter a bed space? What's something they can do?
Yep. I think one of the best things I've discovered is this concept of grace, GRACE. It was a little practice that was developed by this woman who is a Buddhist monk, and she was working with palliative care nurses, adult palliative care nurses, and who were experiencing a lot of burnout. And what this little practice is, it's the acronym is GRACE, and the G stands for gather your attention. So before you put your hands into the incubator, just gather your attention and gather your intention. Recall your intention. So G is gather your attention. Kind of take a break before you throw your hands in. R, recall your intention. Why are you at that child's bedside? And it's not, yes, you've got to do a procedure, you got to do vital signs, but it's really to help bring them back to a place of health and wellness. So recall your intention. And the A is attune to the baby. Read the baby's cues. Are they ready for you? Can you give them a verbal cue and maybe gentle tactile input to help them prepare for what's going to happen before you reach in and flip and strip them? Maybe deleting flipping and stripping from your repertoire altogether, and come up with some type of a sensory communication to introduce your presence. So attune, and then the C is consider then what your options are. So when you look at where the patient's at, your options may be to give the baby a verbal cue and put the hands on, or maybe they look like you can see their little eyes fluttering behind closed lids. Maybe you should go do somebody else up. So when you consider what your next steps are, if you consider and the baby's ready, then the E stands for engage. Go ahead and engage respectfully, slowly, monitoring the baby's response to the interaction, and then end the interaction. And what I recommend is that you frame the care encounter. So the beginning of the care encounter, you give a verbal greeting to the baby, and you put your hands on a non-vulnerable place. And then when you finish the care encounter, do the same thing. Put your hands on the baby and give a verbal, cue that we're all done. Maybe see you in 3 to 4 hours or whatever, but, kind of frame it and if you can do that enough and you can get everybody else to do it, that's actually wiring neural networks to know that, oh, after this second tactile cue, I know that nothing bad's going to happen to me. I mean, and I know things happen, that aren't always scheduled, but I mean, at least it begins that idea. The reference for the GRACE acronym, it's Joan Halifax is the author, and if you just type in the Google, well, yeah, I could send the paper to Kathy also, but if you're impatient, you could just type it into Google, Joan Halifax, and just put the GRACE, and you might even be able to write acronym, but GRACE. And you'll get the paper. I believe it's open access paper. So trying to read anybody else's questions. And
that's amazing.
It's wicked cool. And you know what it does? It helps you too as a clinician. It really,
seems like something that you could put like at the sink, so while we're washing, we could kind of remind ourselves.
Yeah. It just, it slows you down just enough to give you that chance of being present for the baby.
And that would work as a checklist, right? Someone asked, so can we have a checklist of being intentional and mindful? Yeah. There you go. There's your
checklist. Someone asked, discuss briefly the affective neurodevelopmental outcomes related to the isolation of private rooms. I know that you may be referring to that paper that talked about the language challenges of babies that were in the private room environment. I think really, the takeaway message for that is the parents need to be there, and we need to create an environment that is welcoming to the parents so that they will spend as much time as they possibly can there. But a lot of our environments are not welcoming. We may say we have a policy that says parents can be present, 24 hours a day, but do we really set the tone? Do we really make people feel welcome? If I invited you guys all over to my house for a cup of tea, but I only had one tea bag and I had no chairs, you probably wouldn't stay very long. And I think a lot of our NICUs are kind of like that. We say, yeah, they can come, but maybe we have Grumpy Gertie, who's at the front desk, who scares the bark off of anybody. And that's not very welcoming, so we really have to own a lot of this. So, I mean, I know that's the short answer, Paula, and there's much more information about neurodevelopmental outcomes in general. But the idea about private rooms is that they're not isolative, that the parents and the families are there. And I broaden that to families because maybe the parents can't be there 24/7, but can somebody? If you look at the work of the FICARE project up in Canada, where they have an agreement where a family member will be present at a minimum of 8 hours a day. It doesn't always have to be the parents. We have to stop being the barrier and making up these rules that don't really serve anybody at all. I mean, they might serve us because we don't really want the family there, but they really are not in the best interest of the patient. So thinking differently about this stuff. So I encourage you, check out the book. I have lots of implementation strategies and little sample parent teaching sheets in there and other cool things that I think will really help. The book was designed to really take book one and show people how to implement it into your culture of care. And I hope it achieves that on some level. Is this book different than the first? It is. It is different from the first. It's like the part 2 of the first book. The first book introduces the concept. The second book shows you how to do it, shows you how to take these concepts and put them into practice. So it's wicked exciting, and I'm wicked honored to have had this opportunity to follow it up. And again, please feel free to contact me anytime. I'm happy to answer any questions that might bubble up after this talk. Hello?
Thank you, Mary. Amazing. Sorry. I was waiting. Kathy Bush has been having some phone issues, so I want to make sure I was going to give her an opportunity to try to unmute herself. So Kathy Bush, do you want to try to come back on? You might need to do your audio pin. But if not, I will wrap things up for her. going to give her 1 second. So just as a little reminder, so for those people who are watching this as a recording, that we will have sent you an email, and then to get all of your CEUs to access the evaluation, you need to go back to that email and to the resource page. And of course, if you want to do your evaluation, I'll put the link right in the box right now, and sometimes the firewall allows, if you're at the hospital right now, it may or may not allow you to go through, but you'll get an email immediately following the close of this meeting that will give you this link, as well as links to Mary's presentation slides, to some of the references to her flyer, as well as the video, the 2 videos we did try to show, as well as the 3rd one that she decided not to show. If you are doing this as a group, be sure to share the email, the evaluation link that comes in the email, because each person who wants a certificate must actually complete an evaluation. I guess on behalf of Kathy Bush, I'll just say, Mary, you are, as always, amazing and full of so much information and love for the babies that we all serve. And I want to be sure that you know how much we appreciate your time and just your willingness to continue to share for all of us.
Thanks. I'm wicked honored. Thanks.
So Kathy Bush has just made the mention of just Happy Mother's Day to all of you out there as mothers. And thank you, thank you.
Bye-bye. Thanks.